And breastfeeding transmission takes your transmission rate from, you know, under 2% to over 5%. Um, and yes, some of it is from the moms who are not taking their ARVs and their viral loads are going up, but probably about half of the breast milk transmission of babies are moms who seroconvert during pregnancy or breastfeeding. Okay, and if a mom seroconverts, you remember this graph, a patient who's got newly acquired HIV, their viral load is going to be sky high. So a mom who seroconverts during pregnancy or breastfeeding is going to have a very high viral load. So not only is she going to get HIV herself, but she's at a high risk of transmitting to her baby because you know the higher the viral load, the greater the risk of transmitting to the baby. So that's how I got involved in PrEP, and I'm a big advocate for getting every pregnant woman onto PrEP so we can prevent this phenomenon of transmission to not only to the mothers but to the babies as well. But also my interest in PrEP peaked because we were getting helpline requests. So, I run a helpline. We've got this patient. They want to go into PrEP, but the EGFR is 35. And at this point in time, we had nothing for those patients. With injectables, when the injectables come in 3 years' time, yeah, we will have, they'll be able to take those injectables. But at this point in time, with what we have in the DOH, we don't have anything. And people with renal dysfunction are sexually active and should be sexually active. Why should they not be able to go onto PrEP? So then I discovered, well, then there is an agent that's available. I'll talk about it now. It's going to be available at the end of the year on code. It's already available in the private sector. And we got these guidelines. So what guidelines do we had? Okay, we've got the 2021 PrEP guidelines. We've all seen that. And then recently we've got the Clinician Society guidelines, which were, I think, published in July this year. So I thought, great, that's going to have all the stuff for renal dysfunctions. I can advise patients what to do. I looked in there and there was not even a mention of patients with renal dysfunction. I don't know what's going on. So I made some inquiries and I got told, no, there was not enough data. So we couldn't include that. Okay. So that's where we always stuck. And I thought, okay, fine, we're stuck. We'll still have to tell the patients when they phone me from the clinics, patients got renal dysfunction, what do we do for PrEP? I say, sorry, there's no agents available. Right. And then all of a sudden, I discovered the British guidelines for PrEP, published July this year. So around about the same time as the South African ones. And they've also got a very nice little guide, I suppose, for patients more, but it makes it nice and simple. And I will put the links for both of these on the chat later on towards the end of the talk. And don't do it now, Lesejo. I know you've got it, but don't put it on now. And it blew my mind away. It was completely innovative, and it just, yeah, there's renal stuff in there, plenty. Okay. And I thought, well, why are we not doing this kind of stuff? So I want to make you all aware. So this talk is really based a lot on the new British guidelines, but there are, and because it is a national guideline, we've got what to rely on. It's not our guidelines, but it's using the agents that we are using it anyway. So I don't think there's a major train smash. We have to make the decision whether we can use it or not, but we need to know about it. So that's what the first step is, to let you know about it. And then we can make the decision whether we're going to follow it or not. To me, it's simple stuff, and I think we can do it, but it's your choice. Okay, so these are the links. As I say, I will put them on at the end of the talk. This is what I'm going to be talking about. Future PrEP, TDF or TAF, rapid protection, less strict adherence, on-demand PrEP, starting PrEP, stopping PrEP, renal dysfunction, there it is, swallowing difficulty swallowing PrEP and food and hepatitis B. That's what I want to try and cover. But let's start with future PrEP. Okay, because if you look at this, the Clinician Society guidelines, that's what they are brilliant at. Okay, because it's largely put together by researchers who are actually actively involved with these new future drugs. And they know where to inject, the cabotegravir. It's got to be in exactly this place, okay? And how to give the lenacapavir so that you get a raise a little nodule and it doesn't destroy the skin, So they are very skilled at the future stuff. And I think that's beautifully done in these guidelines. But what was worrying me is that we don't have the future stuff yet. Okay, It's going to be probably 3 years before we have the future stuff. What do we do in the meantime? We need some guidance on how to make it better in the meantime. Okay, so let's look at poll number one. I'll quickly find it for you. Okay, poll number one, as you can see, it says there. Oh, it's gone. Oh, there it is. Okay, poll number one, and I'm launching it now. Talking about long-acting PrEP. So this is PrEP, that's the new injectables that we're all talking about. How often are they given? All right, single choice. Once a week, once a month, the CAB once a month, and the lenacapavir every 2 months, the CAB LA every 2 months, the lenacapavir every 6 months, both of them every 6 months, and the honest ones at the bottom, I'm not sure. It's like, I've got so many polls, so I'll get an opportunity to drink, to have a bit of a drink in the middle. Okay.
That's good.
All right, I'm going to give you guys a few more seconds. We'll take it up to a minute, and then I'll end the poll. 5, 4, 3, 2, 1. Okay, that's it. One more chance. Okay, good. Right, we'll end the poll. And let me share the results. Okay, so we got a whole spread, which is great. This is really great because you've got 2 or 3 years to get it right. So don't worry, you've got plenty of time. Okay, so the correct answer is actually the one in the middle. Cabotegravir long-acting every 2 months and lenacapavir every 6 months. Okay, um, you could argue cabotegravir every 1 month because in treatment they used to use every 1 month, but for PrEP purposes, it's going to be every 2 months, which is much better, and then lenacapavir every 6 months. But as I say, you've got a long time before you need to know that. So don't stress too much that only 24% of you got the correct answer. You've got a long time to get it right. Okay. So what are we talking about? So these are the injectables. So this is the cabotegravir. So cabotegravir is like dolutegravir. It's an integrase inhibitor, but it's only has to be given every 2 months. And for treatment, it's being given together with a drug called rilpivirine, also injected every 2 months. 3 mils in each buttock, quite a hefty injection. But it means for the next 2 months, you don't have to do anything for your treatment. And these are the two cardinal studies which showed both in men who have sex with men and with cisgender women, that this was phenomenal, okay, in terms of the response to cabotegravir in terms of preventing infections. You can see in HPT and 083, there were 4 um, injections in the long-acting group, 4 with on-time injections, an additional 3 identified later. And you can see the hazard ratio is 0.34. And in the cisgender woman, okay, there were only 4 injections, four infections, okay. And one was determined to actually have been infected with baseline. And nor to those who had on time. So they had injections on time. Very, very, very powerful. Okay, so that was the first thing to say, yeah, this is great. Okay. And remember what's the important thing about injectables, okay, is that well, let's go back one step. The important thing about a PrEP is, like I said earlier, if you take your PrEP properly, it works. Okay. With injectables, you've got no choice. It's taken for you. You get the injection. As long as you have your injection on time, it's going to work. Okay. If you don't have your injection on time, it won't work. Whereas with it, taking the tablets every day, of course, people, they don't have HIV. It's not like, no urgency to take it, so they may not take it. Okay. So that's the injectable cabotegravir. It's just the integrase inhibitor like dolutegravir. Very good results. Then the other fantastic new kid on the block is lenacapavir. Okay, so lenacapavir is a different drug. It's a capsid inhibitor. It's a brand new drug, and it is given every 6 months. And if you have a look at um, the studies, the two studies, there's purpose 1 and purpose 2, and you can see the transmission rate in purpose 1 was 0 infections with lenacapavir. Okay, and purpose 2, there was, 2 infections out of 1,938 patients. So phenomenal results, and it's only injection every 6 months. So these are fantastic, unbelievable, and this is the future of PrEP for sure. Okay, but how long before we have access to these agents? Okay, I've been told 2, probably more likely 3 years before it's available, and that's will it be accessible to all? Well, at the moment, the price is horrendous. Will they bring the price down enough so people can afford it yet? We hope so, but we don't know that. So will it be accessible? We hope so. Will it be affordable? We hope so. Okay. And it's going to be a while before we get these amazing drugs. So what about our current PrEP, our current pre-exposure prophylaxis? Well, what do we said it's going to take 3 years before we have access to the injectable PrEPs if we can afford it. Maybe we can't afford it, so maybe we might have to continue the current PrEP even longer. So is there something we can do to spruce up our current PrEP in the meantime? Someone asked, is there any studies comparing seroconversion between CAP-LA and LEN? I don't know. I know that I think they have looked at that, but I don't think they've done head-to-heads. But as I say, I'm not an expert on that. You better be more advised to ask the guys who actually are doing these studies. And there are lots of them around in South Africa. But it's a good question. Okay, but that's not what it's all about today. We're not talking about lenacapavir and cabotegravir. We're talking about what our current PrEP is. So is there something we can do to spruce up our current PrEP in the meantime, to put it onto steroids, to make it more active and more attractive? So yes, there is. Okay. So poll number 2, which PrEP agents are currently available, widely available in South Africa? Okay, is it tenofovir FTC, TAF FTC, dapivirine ring, lenacapavir, and abacavir 3TC? Okay, this is pretty quite an easy one. Come on, guys, only 409 of you have answered. I'm expecting at least 600. Come on.
Let's
Oh,
participate,
somebody just
colleagues.
left. We had 78, 781, and somebody left. No, they came back. Okay, that's good. Okay, you don't have to. Okay, it's all anonymous, but please don't leave because I'm asking you to do the polls. Okay, it's all anonymous. Nobody knows, and you don't have to do the polls. Okay, a new person joined. Okay, so they like that. All right, let's end it there. So as you could imagine, let me share the results with you all. 82% you said TDF FTC, and that is correct. That is the main agent that we have today. TAF FTC, we'll see now, is hopefully going to be on the tender in November. Tender in November, it rhymes a bit. And it is widely available in private at the moment. The dapivirine ring, I don't want to say too much about it. It's as far as I know, it is registered in this country. There is a manufacturer. I'm not sure if it is available in the private sector or not, and it's not widely available in the state sector. Dapivirine gives people extra choices, and it's something that the woman can choose to put in herself. If there's if she feels uncomfortable taking oral medication, it's something that she can do on her own, but it's not that effective, right? It's only a 50% efficacy in the best of settings. So it's probably not something we'd be encouraging, but I think it's nice to have choices. So at least if a woman chooses that, can't choose the other PrEP modalities, she can choose them. And lenacapavir is not available, and abacavir 3TC has not been tested. It is available, but it's not been tested for PrEP. People often phone our helpline and say, the patient has got renal dysfunction, can we give them abacavir 3TC? I say, no, we can't because it hasn't been tested for PrEP. Okay, and we've learned with PrEP that you've got to get it right. You've got to test the drugs. You've got to make sure it really works. If it doesn't, because it may not work. It's not to say because it works for treating HIV that it's going to work, because it has to get into the genital tracts in high enough concentrations to prevent acquiring HIV. So it's a good suggestion, but unfortunately, it hasn't been tested yet. Okay, great. We're doing fantastically. Just get rid of this poll. It's in my way. Okay. Right, that was poll number two. So I mentioned TAF there. So what about TAF for PrEP? So what is TAF? You know, everyone says TAF. What is TAF? So TAF stands for tenofovir alafenamide. All right. Tenofovir linked with an alafenamide molecule. The tenofovir that we have at the moment is called TDF. Right? What is TDF? Somebody asked, what's the answer to poll two? I actually went through it all. The main one that we have available is tenofovir FTC, but TAF is available in the private sector and will be available soon. The piperine ring hopefully will be available soon, but not readily available. But the only one that's readily available is going to be TAF, TDF FTC. But thanks for that question. Okay, so what is TAF? So TAF is tenofovir alafenamide. The tenofovir that we have at this point in time in South Africa is not TAF, but TDF. TDF stands for tenofovir disoproxil fumarate. I've heard people say it's tenofovir diphosphate, but that would be spelled with a P and not an F. So it's just tenofovir disoproxil fumarate. So they are both prodrugs of tenofovir. Why do you need prodrugs of tenofovir? Because tenofovir cannot be absorbed into the body on its own. So you need to attach it to something else to allow it to be absorbed. So both TAF and TDF are prodrugs of tenofovir. But TAF has got 91% lower plasma exposure to tenofovir compared to TDF. Remember, the free tenofovir is the baddie, the one that damages the kidneys and the bones. Okay, and if you give tenofovir as TAF, you get 91% less of the dangerous tenofovir. Okay, and so okay, I'll answer that question later on. And so TAF is safer on the kidneys and the bones. All right. And in fact, I'm giving can you believe the whole 1 hour talk on TAF on the 11th of September. And so if you want to know more about it, this is also one of my little babies. I'm happy to talk at length about it. Okay, so TAF is less effective in the kidneys and the bones than TDF. And in fact, you can use TAF from an EGFR of 30, or actually from 15. TAF on its own, you can use an EGFR of 15. TAF with FTC from 30. Although because FTC is like 3TC and it's so safe, you could even go down to an EGFR of 15. So TAF is a wonderful way of giving tenofovir to people with renal dysfunction. So if someone's got hepatitis B and renal dysfunction, HIV, okay, so now we've got an answer. We just give them TAF instead of TDF. So it is going to be on code in the new tender for that purpose. So it's a wonderful drug to have. And as I say, I'm giving a talk on the 11th of September, and we'll unpack it in detail. So look out for that. It's okay. So we've got TDF FTC being used for TAF, it's used for PrEP, TDF FTC, okay, used for PrEP. Can we use TAF FTC for PrEP? So that's our next poll. Okay, I've taught you all about what TAF is. It sounds like it's tenofovir, but just in a safer version for the kidneys. So can we use TAF for PrEP? That's our next poll. Very interesting responses. Okay, I think we can end it there. Oh, they only got 465 people. Okay, we'll have to end it there. All right, and let me share the results with you. Okay, so interestingly enough, 81% of you said in men and women. Okay, but if you ask, well, let's say if you had to ask experts in PrEP 3, 4 months ago, they would say only in men. Okay. And in fact, most people still think that you can only use it in men. So those of you who said men and women, I think you're right. And hopefully I'm going to show you that you're right. But in fact, in the PrEP world, people don't hold by that. People hold that you can only use it in men. And why is that? So let's have a look and see. So the first trial of PrEP was called the Discover trial. Okay. And that was done in high risk men who have sex with men. And they were randomized to either get TAF FTC, 2,600 of them, or TAF TDF FTC, also 2,600 of them. Okay. And if you look at the outcomes in the graph on the right, okay, the light blue one is TAF and the sort of orangey pinkish one is TDF. You can see, in fact, the number of infections in the TAF group was actually lower than in the, this is at week 48 and this is at week 96. You can see the number of infections was lower at both time intervals in those who were on TAF compared to those who were on TDF. Okay, both of them with FTC. But in fact, statistically speaking, they were non-inferior. So although it looked like there were less infections, statistically speaking, they were non-inferior. So it was a big trial, and this is what it was based to say that it is safe. It was tested in men who have sex with men, but generally, um, if it's good for men who have sex with men, it's good for men as well. So for other men as well. So this is what is based on that you can use TAF FTC for PrEP in men. Okay, but what about in women? In women, we did not have any good data. We had some trials that were showing that you couldn't use it. Okay, so this is I got this from another talk. I don't like the terminology, but good data for non-vaginal sex. For people who were not born with vaginas, in other words, for men, there's good data to show that it works. But what about women? What about women who have a vagina, who were born with a vagina? Um, we we didn't, until recently, we did not have any data. And then when they did the Purpose 1 trial, which I showed you earlier with lenacapavir, where you had lenacapavir and they wanted to compare it, okay, to standard of care. So they said, this is our golden opportunity to see if TAF works for PrEP in women. So we'll have the TAF arm, we'll have the sort of lenacapavir arm, and then instead of just having TDF as the comparator arm, we're going to have half of them are going to be F TAF, which is TAF intracytobine, and half are going to be FTDF, which is TDF and intracytobine. So they found this will be a quick way. Yes, we'll show how good lenacapavir is, but we can also at the same time see how good TAF is in women. Okay, and what were the results? I showed you these results earlier, but I didn't emphasize. Okay, we showed that in women, there was 100% efficacy, zero transmissions in the lenacapavir arm. Fantastic. But what about in the other arms? What about in the other arms? Well, let's look at the TDF arm. There were 16 infections. And in the TAF arm, there were 39 infections. Okay, which are very similar to the background incidence. So, in fact, neither of the two arms worked. Lenacapavir worked beautifully, but neither of the two other arms, the FTAF and the TDF intracytobine, worked in women. Okay, like I said to you earlier, if you don't take the drugs, it does not work. And in fact, they found out that these people were not taking these oral drugs, and that's why neither of them worked. And that was sounded like, well, this is the death toll for TAF in women because we do not have any evidence that you can use TAF for PrEP. Until this year in CROI this year, which was February or March, I think, used to be in February, but then it was too cold, so they moved it to March. I remember going to a few years ago in the snow. Okay. So what they did is they said, okay, let's have a look at the people in the study who were taking their TAF and see how many doses they were taking. And so they looked at those who got HIV in the study compared to those who didn't get HIV, the matched controls. And you can see the red is those who have less than 2 doses a week. And you can see the vast predominance in this first column is red, okay, meaning that people who got HIV took less than 2 doses of their TAF FTC in a week. Okay. Whereas those who didn't get HIV took took more doses. Okay, there were more in the groups that took 2 to 3 doses, and in the groups that took more than 4 doses. So they said, well, clearly it is an adherence issue, and they did some very ingenious statistics. Don't ask me how it was done, and they came out with the fact that for those who took more than 2 doses, for those women who took more than 2 doses per week on average, TAF reduced their odds of getting HIV by almost 90%. So basically, it's as good as TDF, not as good as lenacapavir, but as good as TDF. Okay, so based on this, this is not a randomized trial. This is looking at trial, looking at this and pulling out this. Okay, so based on this, it does seem like you can use TAF FTC for PrEP in women. At this stage, the new guidelines came out, and I discussed it with the Clinician Society. I said, why are we not including this? I said, well, there is data, but it's not very good data. And I agree it's not very good data. Okay, next thing is IAS USA approves TAF FTC in women. Okay, next thing, the British guidelines approve TAF FTC in women. So obviously they are happy with this, even though it's not a randomized trial, but they are happy that we can use TAF FTC in women. Okay, based on the statistics that were involved here. Obviously, you need to know someone. You can see p-values 0.0006. That's a very significant p-value. So as I say, I'm not an expert on this, but the experts have spoken. They've said overseas experts are happy that although we don't have a randomized trial, we can use TAF FTC in women. Certainly, I wouldn't be using it in every single woman who walks into your consulting rooms, but in those who perhaps need it because they've got renal dysfunction, they really want to go on to PrEP, you can certainly offer it to them. Okay, so we said there's good for data in men, and in women it's been approved by IAS USA, it's been approved by the British PrEP guidelines, which I've been showing you tonight. Okay. And they say that you should be using, this is the British guidelines recommend use TAF in who? Men and women, okay, who have got renal dysfunction, EGFR above 15, okay, who have got osteoporosis. Obviously, you don't want to be damaging the kidneys, the bones, so also you would want to use it then as well. And in patients, they say patients under 18 years because, young teenagers who, going to have their lives ahead of them, their bones and kidneys are developing. We don't really want to be attacking their bones and kidneys at this point in time. So that's what the British guidelines say, that who should you use TAF FTC? Men and women who've got renal dysfunction, EGFR above 15, up to 60, they go up to 60, osteoporosis, okay, and patients under 18 years of age. So that's who these international guidelines are saying we could use it. Not in everybody, not in every woman, but those obviously where there is an indication for doing it. And also in the British guidelines, they say that right through their guidelines, wherever TDF FTC is used, you can also use TAF FTC. So in other words, we're going to talk a bit later on about on-demand PrEP. So you could use TAF for on-demand PrEP as well. So wherever TDF FTC is used, TAF FTC can also be used. Okay, give me a thumbs up if you guys are following me so far, or thumbs down if you're not. I don't see any thumbs down. Okay, good. So what we've got so far is that we can use TAF in women, all right? We should be selective about which one we use it in, and same with men, only those with renal dysfunction, osteoporosis, and they say under 18 years of age. I mean, you could certainly, if you wanted to, in that situation. All right. So that's, and as I say, it's a very reputable guidelines, have plus IAS USA have approved using it in women. So I don't think that, certainly me, I wouldn't argue with that. You know, some of the people who've got more expertise might not be happy. Okay, but it's a very reputable guidelines. Right. And wherever, as we're going through these guidelines, wherever we talk about using TDF FTC, you could use TAF FTC. TAF FTC is available in the private sector at the moment, and I've been told it's going to be on tender in the new tender in November. Okay, so several studies have shown that efficacy of PrEP is linked to adherence. Like we saw that in that trial of lenacapavir, right? Both of the arms, the TDF and the FTC and the TAF arm, there was no efficacy because they didn't take it, even though they're agents that we know work well, right? If you don't take it, it won't work. And that's why the long-acting injectables work so well, because there's no choice in the matter. If you get your jab, you've taken it for the next 6 months or 2 months. So what can we do to improve adherence in the PrEP modalities that we have? Okay, so as I say, a lot of stuff coming out of these guidelines. And let's do poll number 4. How long does it take for daily PrEP to be active? You've got a patient, you put them onto PrEP. When do you tell them that they should first have their sex? Okay, or stop using barriers if they're going to stop using barriers. How long before daily PrEP becomes active? Is it 2 hours, 1 week, 1 week for males and 3 weeks for females, or 3 weeks for both? Secha, am I asking good questions?
Very important.
Okay, someone asked about PrEP interruption. I'm going to explain that, I hope, in much more detail.
Okay.
What's the resistance profile in patients who seroconvert on TDF FTC? They can get resistance. They can certainly get resistance. If it's just resistance to tenofovir or 3TC, we know it's not a train smash, because we know that we can use dolutegravir with tenofovir FTC as we do in our first-line patients. So that's not a train smash. I'd be more worried in patients who seroconvert with cabotegravir, because then dolutegravir is going to be gone. But they're both good questions. Okay, come on, people. Only 420 of you, not even half, have answered. I should have put in, I'm not sure. Sorry, I should have, because maybe some people are not sure. Okay, I think let's end it there. Yeah, I see some people were not sure. Yeah, okay, good. Let me share the results. Right, so 15% said 2 hours, 51% 1 week, 30% said 1 week for males and 3 weeks for females, and 21% said 3 weeks for both. So, truth be told, when PrEP first came out, I remember many years ago, it was still when the Clinician Society still had meetings in the pharmacy, the pharmacy center, whatever it was called. I don't think it exists, but it's no longer owned by the Pharmaceutical Society. And we had training on that, and they said the third point: 1 week for males and 3 weeks for females. But somewhere along the line, it's shifted as now 1 week for both males and females. So if a patient starts taking their PrEP every single day, it will only be active for PrEP after 1 week. Are you all good with that? It will only be active after 1 week. Okay, listen to me clearly. What about if we get in the rapid protection crew? Instead of waiting 1 week, can't we reduce it? I don't know if I would really want to call these guys out for the looks of them, but I found them on the internet. Okay. But let's look at our rapid protection. Oh, what happened there? Secho, am I still here? Somehow my slides disappeared. Secho, are you good? Are you seeing me? Agree with you, Mervyn. Okay, are the slides up yet? Can you see them? Thumbs up for the slides? Okay, good. Okay, so let's talk about rapid protection. Now the slides don't disappear. So with daily PrEP, as we said, our protection, they tell us, is 7 days. 7 days before PrEP is active. Okay. In the IPAGAY study, which was looking at 211, which we're going to talk about later on. 211 is what they call on-demand PrEP, okay, where we'll talk about it later on. Just done in men. It showed that you could give 2 tablets initially within 24 hours of the sexual activity, and then 1 tablet 24 hours later, and 1 tablet 24 hours later. I'm going to go through that in detail. Okay, and it's using tenofovir and FTC. So in this study, they gave a double dose of tenofovir FTC within 2 to 24 hours of the sexual activity. All right, and then 1 tablet 24 hours later, and 1 tablet 24 hours after that. So it's 2 to 24 hours before, then 24 hours later, and then 48 hours later. And that double dose gives protection within 2 hours. So if you're doing the on-demand PrEP, which means someone has sex infrequently, they're just going to take PrEP just before, their boyfriend or girlfriend is, or boy, let's start with boyfriend because this was done in men with having sex with men. Their boyfriend is overseas and he's coming back and then he's going to go away. They're only not going to see him for very long. So you just want to have protection PrEP for a short time. Okay. So this is where this came out, this 211. We'll talk about it now. But that gives protection within 2 hours. So giving a double dose initially within 24 hours drops your period to become active from 7 days to 2 hours. Okay. So people are saying, well, if that's the case, why don't we give everybody a double dose to start with? Not only those who are, doing the 211, the on-demand PrEP, but even someone else who comes into your clinic and says, I want to be sexually active as soon as possible. They say, sorry, you're going to wait 7 days. Let's do it this way. You only have to wait 2 hours. Why not do that for everybody? Okay, makes sense, right? Anybody thinks it makes sense? Thumbs up. Do you think the patients want to wait a whole week before they know that they've got protection? Let them get protection within 2 hours. Okay. So it reduces your protection time from 7 days to 2 hours. Why not do it for everyone, not just those who are doing on-demand PrEP? And in the British guidelines now, they recommend starting all patients on PrEP with a double dose of either tenofovir FTC or TAF FTC. So even if they're going on to daily PrEP, just give them 2 tablets within 2 to 24 hours of when you're going to start, and it's then active within 2 hours. Okay, so why not? It's not in our guidelines, but what's stopping us from doing this? Nothing, nothing. We're not using any new other medications or anything else. It's exactly what you're prescribing. Just they will start with 2 tablets as the first dose, and then have protection within 2 hours, and then after that, go on to daily. And why shouldn't we do this in South Africa? I'm asking, but it's in the British guidelines. Overseas people are doing it, but we're not doing it in South Africa. Let me see if there are pressing questions here. Right, Mervyn says quite clearly, and Mervyn, we're going to address that, I hope. Not everyone wants to take PrEP daily, especially if they have sex occasionally, 100%. So you don't have to, some people want to go on to daily PrEP, others only want to take it when necessary. So yes, we'll talk about that now, but I'm talking about even people who are going on to daily PrEP. Why not start them with 2 tablets to start with, okay, and that will give them protection within 2 hours, not 7 days. Okay, poll number 5. How many doses a week do people need to take for PrEP to be active? Is it 2, 3, 4, 5, 6, or 7? How many doses a week do people need to take their PrEP for it to be active?
Interesting, this one.
It is very interesting. But Lesego, don't you think this whole thing is interesting?
Everything.
Yeah, it's amazing.
I'm getting empowered myself and learning. And you see, like this question,
Oh,
when we get it right, we would know how best to advise patients and remove a
right.
lot of guilt.
Yeah, yeah. Someone says that in Eswatini they're already also giving 2 tablets initially when they're starting on daily PrEP. So
Okay.
Eswatini is beating us.
Hmm.
So Paul, I'll explain. If I haven't explained it properly, ask your question again. Um, Someone asked a very good question. Will this still protect people with the partners on third line? So if you know your partner's on third line, I probably wouldn't. I probably wouldn't do this. But as a population, yes, it is protecting. Because remember, the number of people on third line is very few. So as a population, we are getting excellent protection. But if someone knows their partner's on third line, I don't think I would rely on just using this as PrEP, to be quite honest. Okay, let's end this now. Share the results. So yeah, a lot of people said 7 days. 56% said 7 days. Some said 6. Some said 5, 4, 3. I went down to 2. Okay, so we saw that. We saw that on that on the PrEP trial with the lenacapavir that 2 didn't work. You could see that 2 didn't work. So 2 probably I wouldn't say 2 doses a week. But let's see what the experts say. Okay, so patients who are on continuous PrEP, okay, 4 doses is likely to give good protection. This is what the British guidelines say. So they say the patient should, you wouldn't start with 4 doses a week, but once they've had a continuous, for the first week, then you could actually switch to 4 doses a week. And they even talk about TTSS dosing, which stands for Tuesday, Thursday, Saturday, Sunday. So Tuesday, Thursday, Saturday, Sunday, they say it may be an option where reduced dosing is indicated, maybe because of toxicity or event-based dosing is not suitable, then you could do that. I must say, my gut feeling is I would still encourage daily dosing, but if adherence is an issue, you've got to make sure that they're taking at least 4 doses a week. I don't know. I don't like tell people they can miss so many doses because they'll make sure that that's how many doses they miss. But I think I would say, you need to make sure go for daily dosing, but if you don't manage it, just make sure you're getting at least 4 doses in a week, which is a lot different from trying to get every single dose in, you know what I'm saying? All right, so let's talk about on-demand PrEP. What is on-demand PrEP? So let me just launch the poll. Poll 6. So what is on-demand PrEP? Okay, so someone asked this. So on-demand PrEP is continuous PrEP is when you take PrEP, you start today. Hopefully you'll start today with 2 doses and then you'll go on daily PrEP and you continue. We'll talk about when you stop, but for as long as you need to, as long as you are exposed, you can continue with that PrEP. Okay, but then as Mervyn said, some people say, look, I don't have sex all that often. I don't want to go into PrEP for months and months and months and months when I'm only going to have sex maybe in 3 months' time, and it's going to be, you know, I'm going to know when it's going to happen. Can't I just take something just before? So whenever I need to, that's on-demand PrEP. Okay, and it's very useful if people are having infrequent sex. If they're having frequent sex, they should be on daily PrEP. Okay, because it's happening all the time, they should be on daily PrEP. But if it's infrequent, okay, and you've got 2 hours leeway. Remember, you can do it with, you've got a 2 hour, you need to do this before 2 hours, right? So look, I don't know. I don't know what goes on out there, but I think it's probably not that common that you'll meet a person and have sex with him within 2 hours. You know what I'm saying? So if so, you could say, let's wait for a little bit for my prep to work. So it's within 2 hours, you can do this on-demand prep. Okay. So on-demand prep is where you give prep to people who only need it for a short period of time. Okay, they're not sexually active that often, infrequently, and they would, when would you give prep to them? On-demand prep. We're going to talk about now. Let's end the poll, and I'll show you the responses. Okay, so 48% said men only, 45% said women, few said neither, and some honest people said they're not sure. And there was someone in the Q&A who put it very well. Okay. On-demand prep for men, for people assigned male at birth and not on any exogenous hormones. Okay, so that's what, like I said, that's what we all thought. Okay, that's what we were all told. So let's have a look at it. So to answer the poll, at this point in time, basically people who are born as men, okay, can use PrEP and women should not, can use on-demand PrEP and women should not be using on-demand PrEP. And the reason is because it hadn't been shown to work, okay? Because remember the antiretrovirals don't get into the female genital tract as easily as they do in the male. And so there could be a differential. But let's have a look and see what the guidelines are saying. So on-demand PrEP, classically this was called the 2-1-1 dosing. It is available. You can use it in South Africa, not a problem for people to say, listen, I don't have sex that often. I want something just at the time I'm having sex because it's going to be months before I have it again. I don't want to go on daily prep for months and months and months. Okay, so this is what we call the 2-1-1 dosing. What does it entail? You're taking two tablets, either tenofovir TDF FTC or TAF FTC, 2 to 24 hours before the high risk activity, and then one tablet approximately 24 hours to 48 hours after that. So I'll take you through that. Okay. And who is supposed to be taking, who should be taking this 2-1-1? Men, because it's been shown not to work in women. So as someone said, men, people who were born men and male and not on hormones. Okay. But then they've come up with a 2-7 dosing, which is pretty new. 2-7 dosing means taking two of these tablets, either tenofovir FTC or TAF FTC, 2 to 24 hours before, and then one tablet daily for 7 hours after the initial double dose. So I'm going to show you graphically what that all entails. And this can be used by women. Okay. So let's look at our on-demand test dosing. This comes from that booklet that I showed you, also put out by in the UK, but more for patients, right? So the 2-1-1 dosing, event-based dosing, right? This is someone who's going to have sex once, all right? But they don't have it very frequently. They know that they're going to have it. So between 2 or 24 hours before they know they're going to have it, they're going to take their two tablets at the bottom, right? That's on Wednesday. They know they're going to have sex on Thursday. So between 2 to 24 hours before, they're going to, or it looks like it's maybe Wednesday night, all right? So they're going to have the two tablets before. So maybe they take it Wednesday morning or Wednesday afternoon. Then they have their sex on Wednesday night. And then on Thursday, 24 hours after the initial dose, so let's say they took it Wednesday afternoon. So Thursday afternoon, they're going to take one tablet. And Friday afternoon, they're going to take one tablet. That's a 2-1-1. So the first two is 2 to 24 hours before having sex. All right. So anywhere between 2 to 24 hours before they're going to have sex, they take two. And then whatever time they took those two, 24 hours later, they're going to take one. And 24 hours after that one, they're going to take another one. So that's 2-1-1. So it's 2 to 24 hours before sex. Then 24 hours, you take two tablets. 24 hours later, just one. 24 hours after that, you take one. Okay. Are we all good with that? Give me thumbs up if you all understand that. Great. So that's a 2-on-1. Okay. Now, send me a happy face if you have used 2-on-1 on any of your patients. I've got one happy face coming through. Two, not too many happy faces. Okay. Okay, a couple. Couple. Okay, good. All right. So this is 2-on-1. This, we were told, can only be used in men. All right. As someone says quite clearly, men who are born assigned or born male at birth and are not on any hormones. Okay. Now, what happens if this guy, he had his sex and then he gets lucky the next day? Oh, now what does he do? He's got 2-on-1, but now what does he do now? The person from last night says, I want to tonight again. Okay, he should be so lucky, right? So then you can continue with the 2-on-1. So if you have sex in a few days, you can carry on taking one tablet every day. So you took your two tablets 2 to 24 hours before. Okay, you had sex that night. 24 hours after the first two, you take it again. And then, oops, I've got tonight as well. Okay, well, I'll carry on and I'll carry on taking it. And as long as you make sure that after the last event of sex, you take it for another 2 days after that. So you could continue, even though it's on demand, if your boyfriend comes from overseas, right? And then, it's not going to be a once off, but you don't have to go into daily PrEP for that. You can do the 2-on-1, but you can extend it as long as the sexual activity continues and continue for another 48 hours afterwards, 2 doses after the sex has stopped. Okay. Are we all good with that? Give us a thumbs up. So the 2-on-1, extending it to longer if the sex continues. Okay, right. Now, what about this one that is little known, the 2-7 dosing? I must say, I did find it in the Clinician Society guidelines. It's right at the back for the future. It says for the future, when we get more data, it's something that we could use. Okay, now this is, I don't know the science behind it, but the British guidelines are quite comfortable saying that women can use it. I'll give you the guidelines and you're welcome to interrogate it and have a look and see. And it can be used, as I say, by cis women, okay, and trans and non-binary people having receptive vaginal or frontal sex. I don't understand what that means, but I'm hoping people out there know what that means. So basically, um, people who are born women, okay, and people who become women, I suppose, and people who are not sure what they are. I don't know exactly what it all means, but it's all there, and I hope that you understand this. So what is the 2-7 dosing? So you start off with two tablets, just like we always do, 2 to 24 hours before sex. They're going to have their two tablets, and it's either going to be tenofovir FTC, TDF FTC or TAF FTC. Okay, so I hope I answered why 2-on-1 is not doesn't work in women, because the drugs don't get into the female genital tract quickly enough in sufficiently and for it to be able to be used as 2-on-1. Okay, but you can use it as 2-7 dosing. In other words, it'll get in quickly enough, but you need to continue for 7 days, and that's where the 2-7 dosing comes in. So how the 2-7 dosing works is you're going to take your two tablets 2 to 24 hours before the sex as standard, and then you don't do 2-1-1, but you can do 2-1-1-1-1-1-1-1, meaning 7. Okay. So 2 initially and 7 after that. So it's going to be 9 tablets in total. So in other words, same scenario. The person discovers on Wednesday afternoon they're going to have sex that night. So they take their 2 tablets on Wednesday afternoon, or let's say Wednesday morning. They take it on Wednesday morning. The next day, they have sex that night. The next day, in the morning, Thursday morning, they have one. That's the first one. Friday morning, they have another one. That's the second. Saturday, another one. That's the third. Sunday, the fourth. Monday, the fifth. Tuesday, the sixth. Wednesday morning is the seventh. That's the 2-7 dosing. And that you can use for women. Okay, so simplified, okay, you know the details, but for men, generally, they can take the 2-1-1. In women, they would have to take 2-7 dosing. Okay, for on-demand PrEP. In other words, it's infrequent sex, just want to take it when it happens, but you don't want to be on daily PrEP for months and months and months for something that's not necessarily going to happen. Okay. In addition, and some interesting things that I've discovered, that the EPIC hair study, they looked at hair samples of people who were doing PrEP, and they showed that there was a higher decline in renal function for those with higher drug level concentrations. In other words, if you took, you can see here on the graph on the left, if you took 7 doses a week, you're going to have a much bigger drop in your renal function than if you take 4 to 6 or 2 to 3 doses a week. So if you can reduce the number of doses you're taking in a week, you could actually, help the kidneys. So, for example, like we learned, you can take 4 doses a week rather than 7. That would be good if someone's got renal dysfunction and you haven't got another option. You haven't got TAF in the DOH. Or you could do on demand, okay? Because if you're doing on demand, this was another study which showed um, from Dr. Molina, showed that those who did on demand PrEP, okay, they had less of a drop in their creatinine clearance. It's not majorly, but it was less. So in our setting now where we don't have um, TAF available in the DOH, you could say, look, rather than do it daily, just do on demand because you'll have less of an effect on your kidneys. If their renal, let's say the EGFR is sort of 50, 51, 52 there, but you don't want to put them on daily PrEP, but you might say, well, let's go for on demand because we can also save your kidneys that way. So there may be a place there for using either the 2-1-1 or the 2-7 dosing to protect the kidneys where TAF is not yet available. Okay, poll number 7. We've only got 2 more polls, so don't worry, those of you who think I'm going to go the whole night. I've only got 2 more polls. Poll number 7. I think there's one, there's 10, sorry, there's 3 more. It's only problem when you've got lots of polls, it's hard to find them. Okay, poll number 7. There we go. How do you stop PrEP? So you've got a patient, they're taking their PrEP, taking their daily PrEP. When should they stop taking their PrEP? How long after the last sex should they stop taking their PrEP? Should it be continued for an extra 2 days in men, 2 days in women, 7 days in men and women, 7 days in men, 7 days in women, or 28 days? So make it post-exposure prophylaxis. And the last one, which I see some brave people have answered, I'm confusing you with all these numbers. Someone asked you, do any baseline blood? I would do the same baseline bloods. But the problem is you're not necessarily going to be there at the baseline when it happens. You might have this conversation quite long before, but I would still do the baseline bloods, same as you would do it with normal PrEP. Someone asked a very good question. Is it a must take PrEP if the partner is adherent to their medication? So if the partner has a suppressed, we can discuss this later, I think, as well. If the partner has a suppressed viral load, Okay, U equals U applies, and there is no risk of transmission. But remember, the decision not to use condoms is not an individual choice, it's a couple's choice. And it depends on what your partner feels comfortable with. Some couples, the partner, the unaffected partner, wants to be on PrEP, and that's their choice. Is it necessary? No. If the other partner has an undetectable viral load, it's not necessary, but maybe they're worried about the adherence of the infected partner. Maybe they're worried about other infections. Remember, you can bring other infections into a relationship, not just HIV, and so they might want to continue using condoms. So if the viral load is suppressed in the infected partner, the uninfected partner, if they've been suppressed for 6 months, the uninfected partner does not need to go onto PrEP, but it's their choice. And if they want to, if it reduces the anxiety, they can. There's no problem. But medically, do they need to? No. But maybe they're worried that the partner is suppressed, will be unsuppressed tomorrow because they don't take the treatment that often. You know what I'm saying? So it's something that you have to do counseling, and the couple must decide. Okay, so let's have a look at our poll. I'm going to end the poll there. Oh, it's a bit slow today. The ending, it's not ending. So it doesn't want to end. Oh, there we go. I'm sharing the results with you. Okay, so 47% said 7 days in men and women, 9% said 2 days in women, 26% said 2 days in men. Okay, 1% said 7 days, 18% said 7 days in women, and 28%, 15% were confused. Okay, that's fine. But if you think about it from the 211, what we're talking about, that in 211, how many days do men carry on taking their PrEP? 2 days. It's 2 days initially, and then 2 days afterwards. And women, how many days in their on-demand PrEP do they carry on taking it? 7 days. So you could work it out. Let's see what the guidelines say. So this is what the British guidelines are saying. Start all PrEP, like we said, with 2 tablets of either TDF FTC or TAF FTC for rapid protection. Okay, so you don't wait a whole 7 days. Within 2 hours, it is active. That we got already. But what about stopping? So if you're stopping PrEP in men, they say you continue for another 2 days after the last high risk activity, like we said with the 211, right? If 211 works, well, then same thing, someone's taking continuous PrEP, well, then if they take 2 more doses, 24 hours and 48 hours after the last act of sex, that should be enough. So that's what you need to do. That's how you advise them to stop their PrEP. If they are on daily PrEP, if it's a male patient, they would stop it, go for another 2 days after the last high-risk sexual activity, and then they could stop their PrEP. And if it's a female, there the 2-7 rule applies. They would continue for another 7 days after the last high-risk activity. So it makes sense of what we learned about on-demand PrEP. So even they're going to go for daily PrEP and you want to stop it, because some people do want to stop it at some stage. How do you stop it? In males, 2 days after the last act of sex. In females, you continue for another 7 days after the last act of sex. Okay, and this is the highly technical stuff from the guidelines. All right, so I'll take you through it. So first of all, saying this is a summary from the actual British guidelines, saying, and they're talking about either saying tenofovir FTC or TAF FTC, fixed dose combinations. If a patient is receiving receptive anal sex, your time to start, we said two tablets, 2 to 24 hours before, stopping 2 days after the last risk. Okay, and restarting, if it's less than 7 days since the last dose, you don't have to give a double dose. You can start with a single dose. If they're having insertive vaginal or neovaginal anal sex, okay, then it would, so this is really talking about males as well. You would have your double dose before, 2 to 24 hours before, two tablets, and then stopping it, as in the first case, 2 days, continue for the single dose for 2 days after last risk. And once again, if you want to restart, if it's less than 7 days since your last dose, you could actually just restart with a single dose. You don't have to give 2 tablets. Now, what about the next one? Those who are having receptive vaginal or neovaginal sex, or those with injection drug use. So receptive vaginal and neovaginal sex. Okay, once again, starting it with 2 tablets, 2 to 24 hours before the risk, and continue for 7 days after last risk. And restarting with a single dose if it's less than 3 days. So if it's less than 3 days since the last dose, you don't have to give a double dose when you're starting. You can just give a single dose. And same thing goes with injection drug risk. Well, we know that protection is less with injection drugs, but people who are injecting themselves also have sex. So you want to protect them as well. And you would start with 2 tablets, 2 to 24 hours before the risk, and continue daily for 7 days after the last risk. And this is still slightly different. If it's less than 4 days since the last dose and you want to restart it, then you can use a single dose. Otherwise, you'd start with a double dose. Okay, so this is a bit more complicated, but um, broadly speaking, if it's a male patient, then it's going to be, you would stop after you take 2 additional doses. And broadly speaking, if it's a female patient, you would take an additional 7 doses after the last high risk activity. All right, are we all good so far? I know it's a little bit confusing, but I would strongly recommend that you download those 2 documents. And in fact, the one that's for patients is done very, very nicely. With those diagrams I showed you is from that. So it makes it much, much easier. Both for us, I must say, I learned probably more from that than from the actual complicated guidelines because they're actually quite difficult. But that little patient booklet is really helpful. Okay, thank you. Right, renal dysfunction and PrEP. So we spoke about TAF. Okay, so what are options with patients with renal dysfunction? So what we have at the moment in the States, Tenofovir and FTC, you can only use from above an EGFR of 50. TAF FTC, they say down to an EGFR of 30, but you could go down to 15 because the TAF itself can go down to EGFR of 15. The FTC, they say, should only be above 30, but we know FTC, like 3TC, is a very safe drug and people are quite comfortable using it right down to 15 because even though your levels will go up, it's a very safe drug, so it's not a big deal. Cabotegravir and lenacapavir can be used, okay, at with any renal function, as can dapivirine, but we know it's unfortunately not as active. So I'm hoping that certainly in the private sector we should be using TAF, FTAF, TAF, FTC for all our patients with renal dysfunction who need PrEP, and hopefully it will be available for this function in the DOH in the months to come. But once the injectables come in, of course, then, but that's 3 years' time. You're not going to tell someone, wait for 3 years before you can have sex, right? Okay, we've got to do something now. Okay, what about gastrointestinal side effects? So I've this week literally had a patient went onto PrEP and was vomiting, couldn't take the PrEP, so you think it's all hunky-dory, vomiting. Okay, so how can we deal with the GI effects of PrEP? And this is all in the guidelines. 5 to 11% of users will get nausea, gastrointestinal nausea, vomiting, or diarrhea, 5 to 11%, and it's usually within a month of starting, and it usually regresses within 3 months. Okay, but not everybody will stick it out for the whole 3 months. Okay, if it makes them nauseous, you can try giving it with food. That may work. Okay, if the double dose is making them nauseous, you can split it as long as they're given between 2 and 24 hours. So you can give, let's say you can give one, let's say the patient can have sex on Wednesday at 9 o'clock, so that they must have taken their double dose before 7 o'clock Wednesday evening. So they could take one, Wednesday morning, and then one at 6 o'clock Wednesday evening. So as long as both are within 24 hours before having sex and both are before 2 hours, you could split it like that as long as you've taken 2 tablets within a period of 24 hours to 2 hours before having the sex. That counts as 2 tablets. So that's a way you can, if the double dose is giving them problems, they can split that double dose in that period between 24 hours and 2 hours before. But if the double dose is an issue, even that they're worrying, then daily PrEP may be a better option, because if the double dose is affecting them, it may be a better option. If PrEP is giving them, daily PrEP is giving them an option, then maybe that that on-demand PrEP might be better because it's only for a shorter time. So, you have to discuss with the patient and come to an answer. You can use symptomatic treatment with antiemetics, muscarinic antagonists, and antidiarrheal medication in more severe cases if you need to. And they also say that sometimes if you change the prescription, because it may not be the actual antiretrovirals that are causing the GI side effects, but maybe the excipients. So in that case, changing to another brand might be helpful as well. And they do say that in the Discover trial, okay, there was no difference in GI adverse events between TDF, FTC, or TAF FTC. But I don't know, the incidence is the same, but maybe it's worthwhile trying the one. I know I tried that with my patient. I'll let you, I don't know if it's working or not, but I did try that. Instead of using TDF FTC, I used TAF FTC. I still don't know if it's going to work or not, but it's maybe worth trying. All right, what about PrEP and food? So I don't know if people know this, but the tenofovir area under the curve is increased by 40% with TDF FTC and 60% with TAF FTC if it's taken with a high-fat meal. It's got to be a good, solid, high-fat meal, okay, compared to fasting, but not with a light meal, okay. So it's not really of any major consequence. The Cmax is also increased with TDF FTC, but not with TAF FTC. But we said dosing with food may reduce the gastrointestinal side effects, but I probably wouldn't give them a high-fat meal, okay, because that's going to increase the absorption of the area under the curve, okay. But they say that if you're concerned about absorption or drug levels, for example, PrEP is taken after exposure. You should be taking, post-exposure prophylaxis, PEP, or the patient misses a dose. You might want to then recommend they miss a dose, take your next dose with a high-fat meal to get a rapidly increase of your levels. Just something to think of. It's not something that I think we need to definitely do in every case. Okay, let's do poll number 8. We're running out of time, so we better go quickly. Let's do poll number 8 quickly. Poll number 8, hepatitis B. Well, we're into the cardios here. Poll number 8, there we go. Hepatitis B and PrEP. Patient with hepatitis B who is taking tenofovir FTC for PrEP. If they stop their PrEP, they will, oh, it said fail to launch. Let me try again. Sorry. If it says, oh, there we go. If they stop their PrEP, they will develop a flare-up of hepatitis B. This is multiple choice, right? They should never stop their PrEP. They should only use daily PrEP and not on-demand PrEP. All of the above or none of the above. The second, have you got something on at 8? Is it a hard stop?
No, we don't have coaching programs, so I think we can continue maybe for another
All right,
5
okay.
to
I'll
10
try
minutes.
and finish.
Yeah, yeah, sure.
It's taking me a bit longer than what I thought it would. Okay, let's finish off now. Oh, sorry, I can't end this poll.
Should I end it on my side?
Yeah, can you end the poll for me? For some reason, it's not allowing me to. There we go. Okay, I've got it now. Okay, and share results. Okay. Oh, failed to share poll.
Yeah, can you see it?
All right,
We can see it. We can
oh,
see
can you
the
see it? Okay.
results. Yeah.
All right. Okay. So 16% said you'll get a flare-up of hepatitis B. That's what we were always taught, right? Should never stop their PrEP. That's what we always taught. Okay, 26% says only daily and not on demand because you don't want to stop it. 39% all of the above and 10% did none of the above. Let's see what the British guidelines say. I was surprised when I saw this. Okay, what do they say? First of all, we know that obviously every patient starting PrEP should be tested for hepatitis B and should do both a surface antigen and an antibody. Why? Because if they're antibody negative, they're not immune. Okay, you want to immunize them against hepatitis B because you don't want to be in a situation where they're going to pick up hepatitis B from their high risk sexual activities. Okay, so it's a good idea to not just do her surface antigen, which will tell you if they've got hepatitis B or not, but the antibody, which will tell you if they're immune or not. Okay, but let's say they are hepatitis B surface antigen positive, they have got hepatitis B. So we were told that if you stop this tenofovir in patients with hepatitis B, there's going to get this flare up of their hepatitis B, but apparently it's a very small risk. It's only a very small risk. Okay, there is limited published evidence evaluating the risk of hepatitis B reactivation in people who are on oral uh, um, PrEP with chronic hepatitis B. So there's very little evidence saying that there is a risk or not. The flare-ups do appear to be very rare, particularly in patients who've got normal baseline LFTs and no fibrotic liver disease. So you do an ALT, we can't test for fibrotic liver disease generally, but if the ALT is normal, then WHO is actually recommending that both daily and on-demand PrEP can be offered to people with hepatitis B virus. That means you can go on to daily and you can go on to the on-demand and stop it when it's finished. That I didn't know. But those with hepatitis B should be counseled. There's a potential risk of reactivation if the PrEP is stopped, and they will require regular monitoring with hepatitis B DNA and liver function tests up to 12 months after PrEP discontinuation, if not on other hepatitis B treatment. So you need to counsel the patient with hepatitis B and saying, look, you may have a flare-up. It's very rare, but if you do, then we might have to do something about it. But obviously, if the patient needs treatment for hepatitis B, then they should be starting on treatment for hepatitis B then. And if they do need treatment for hepatitis B, well then, if they need treatment for hepatitis B, then I would use daily PrEP. I wouldn't use on demand. Okay, so our last little poll. If you could quickly do it. Poll number 9, 97. Oh, it goes up to 99. So we can keep going. We've got up to 99 polls here. Okay. Poll number 9. Anonymous. Oh, it's slow tonight, eh, Lesejo? Slow to launch. Let's
Okay,
try
cool.
again.
It has launched. Did you see?
Yeah,
Okay.
now it's launched. Yeah,
Okay.
now it's launched. Uh-oh. Someone answered that they learned nothing tonight. Okay, well, I apologize to those people who learned nothing tonight. Apologies to you. Okay, let's end the poll there. Share the results. So thank you so much to everybody. I see that 99% of you did learn something new tonight. But for those 3 people, I hope I didn't waste your time. I'm sorry. Okay. Lesejo, mind-blowing, hey?
Mind blowing, mind blowing. But it's getting us closer to person-centered care, because
Right,
there's people are not the same and their needs are not the same, and we can't just use one size fits all. We need to look at
right,
what works for me versus someone else, etc., etc. So I thought that was awesome, Leon.
right, right.
Um,
Yeah, I mean, look, this is not in our guidelines, but there's a lot of stuff here that you can do
mm,
that you don't have to. I mean, the 2 tablets to start with, you can certainly do. And the 2-on-1 and the 2-7, you can certainly do it. You're not using medications that aren't available. If someone says, I don't want to go into PrEP all
mm,
the time, I just need to go every now and again, well, then you can offer them, if it's a male, 2-1, and if it's a female, you can offer them a 2-7. Okay,
mm.
I did try to answer a lot of the questions as we went, but
Yes.
let's just try and see what we can. So this is
Okay.
not PrEP related, but I think it's a very important one. They wanted to check the guidelines say not to give TLD if in pregnant women if the creatinine is 85 micromoles or more. does that mean we should rather switch them to ALD? Okay. And then they say if they qualify for, if they've got hepatitis B, then should they go back to TLD after pregnancy? Okay. So that's a very good question. So the first thing, let's take out the hepatitis B. So we know that in pregnancy, we use the MDRD formula, which is quite a complicated formula, but you can get an app on your phone to do it. But in pregnancy, because of all the excess fluids on board, okay, these formulas don't work. So in pregnancy, we use an absolute value of 85 micromoles per liter. If the creatinine is below 85 micromoles per liter, you can use TLD. If it's not, you would then want to use an alternative. Okay, if they don't have hepatitis B, then you could use ALD. Um, if they have hepatitis B, it's a different story. At this point in time, we do have renal doses of tenofovir which you can use, or alternatively, you could use TAF um, for in that situation. But you couldn't use full TLD if a patient who's got renal dysfunction, which in pregnancy is going to be an EGFR below 85. Okay, I hope that answers that question. Um, Mervin's had some really good comments. Thanks, Mervin. Um, okay, Paul, I hope I answered your question about the 211. So two initially, and then one after that, and one after that, and then obviously 27 in females. Right, Mervin makes a good point. If someone is on third line treatment, that they should have had resistance testing, and you should be able to know what their profile is. Very good. But I would still be using condoms in that situation. Uh, Olubumi answer, good question. I don't know the answer. Feasibility of developing resistance when comparing intermittent PrEP to continuous dosing. I don't think it's an issue. I haven't seen it that it's an issue, but I don't know the answer to that. Sorry. Okay, someone's got a problem with HIV negative pregnant women who don't want to take their PrEP because they say they trust their partners. No matter how much you educate them, they are still. I think it is a problem. Um, I think what you need to do is quote them the statistics. Okay, in that we are seeing high numbers of women that are seroconverting during late pregnancy or during breastfeeding. Okay, and it seems to be I don't know for sure. It seems to be a cultural kind of thing. Is that in that the for some reason the men think maybe sex is infrequent in the last trimester of pregnancy or when they're breastfeeding or whatever it is. For some reason, the men tend to stray at that time, stray out of the relationship, pick up HIV, come back and give it to the woman, okay, who's now at high risk of not only getting HIV herself, but also to passing it on to the baby. And I think you can just say the statistics show that even the most trustworthy men, trustworthy the rest of the time, when they are not getting sex for a long period of time, that sometimes they do stray, and it's worthwhile trying it. Obviously, you can't always convince them, but I think you just quote the statistics, and that you don't want to become one of the statistics. But at the end of the day, it's her choice. Is there issues of drug resistance in use of oral PrEP? Not majorly. Generally, the situation where people will get resistance to oral PrEP is when they have HIV already and it hasn't been picked up. Okay, they've had HIV already, that the test misses it. Maybe they in the what's it, what's the name period? I've gone blank. But they haven't they have HIV, it's not showing on the test yet, and that's usually where they may develop resistance. But with oral PrEP, remember tenofovir and FTC, and they're going to go into TLD after that. It's not a big train smash. But with the injectables, with cabotegravir and lenacapavir, which is lenacapavir has got a low genetic barrier to resistance, becomes resistant very easy, just like the efavirenz used to. So the patient's already got HIV and they given lenacapavir, they're going to get resistance to lenacapavir for sure. Okay, but it's not such a major issue with oral PrEP, and especially if you're making sure that the patients are HIV negative, the window period I was talking about, right? So if you get them in the window period, that they test negative, and you're then going to put them onto PrEP, and actually they have got HIV. So that's more an issue than actually that PrEP is not working. But if people are not taking PrEP, of course, it can work, and yes, you can get resistance, but I don't think it's a major it's a major risk. Okay. Okay, I've answered that one. Um, so I was asked too, am I not recommending in females? Because as I said, the penetration of the drugs is not as good in the female genital tract as it is in the male genital tract. It takes longer. Okay, we mentioned that one here. All right, someone asked about U equals U. Remember that if you've got an infected partner, you have to have the discussion with them, and the couple must decide what they want to do. And the choices can be that if the infected partner has got an unchecked viral load, they can say, we as a couple trust each other, we don't want to use condoms, and they can abandon condoms. That's their choice. All right. Could be they'll say, look, I'm not so comfortable doing this. I want to just carry on using condoms. That's fine. You can use condoms. Some say, look, I'm anxious about even using condoms. I want to use PrEP, and that's also fine. If they want to have a baby, okay, and they're using condoms, now they want to have a baby, what do they do? So if the infected partner is uninfected, I would actually do a viral load just before they want to have a baby. Make sure that the infected partner is suppressed. Then they could stop using condoms just at the time of the month when she can fall pregnant and they can have a baby naturally. If the other partner is not happy with that, they might want to go into PrEP at that time. Is it necessary? No, because the infected partner is suppressed. But you're treating the anxiety. So in all of this, it's not just looking at risk of HIV, it's looking at the anxiety levels of the other partner. And that's why the decision of what to do with U equals U with discordant couples is a couple's choice. And we have to respect the couple's decision. I hope that helps. Okay, someone asked, can the partner comes for a week or a month for a visit? Can it be modified? We said that, right? The PrEP on demand, you can continue. They come for a month. So you say 2 to 24 hours before it starts. Then you continue with daily after that until they leave. And then if it's a male person who's taking it, they would then go for 2 more doses afterwards. If it's a female person taking it, they will go for 7 doses afterwards. So you definitely can modify it if the sexual activity is going to go, if it's on demand, but it's going to go on for a longer time. I hope I explained that. What happens if a woman has sex a day after the initial date? Like we said, as long as she goes for an additional 7 days after the last time she has sex, that is fine. So she can keep on going. Let's say the partner comes back, going to be there for a month and then go away. So for the whole month, she doesn't have to take, and it only comes once a year. She doesn't have to take PrEP the whole year. She just takes PrEP 2 to 24 hours double dose before it starts, continues, and then continue for 7 days after the sex ends. How does a viral blip affect U equals U? So we know that if it is a proper viral blip, okay, and it's a blip where the viral load pops up, they say under 1,000, but generally under 500, okay, and it goes back down again. A blip, generally they say that if you take blood 5 times a day in a person who's virus suppressed, okay, in one of the five you will find virus. So that's what a blip is. You happen to take blood at the time when that person had a little puff of replication. So it doesn't, if it's a proper blip, it will not affect U equals U. If it is, early treatment failure, that's a different story. Or it's persistent low level viremia, that will affect U equals U. But a simple blip is not going to affect U equals U because they are still suppressed. So Mervyn agrees with what the British guidelines say. If a person with chronic HPV is on PrEP and they take it intermittently, there's a risk of hepatitis B related pathology. So they're saying if they qualify for treatment for hepatitis B, you should rather give them daily. But if they don't qualify for treatment for hepatitis B, they say you can use intermittent. I say no, you need to argue with the guys in the guidelines. I know Mervyn, you also from the UK, so you probably know those guys, and you can discuss it with them. Okay, that's good. Thank you for that. Wow, that is a very nice one. Thank you. Because I'm not an expert in PrEP. Someone said I explain PrEP better than it's ever been explained to me. Thank you. I don't profess to be an expert in PrEP. I just saw this. I thought this is amazing. I have to show it to everybody else. But I'm not an expert. So thank you for that. I appreciate it. Okay. Someone says a person-centered care is going to give us a headache because one patient was talking to another, complaining they're not receiving the same regimen. So yeah, but you know what? That's with everything new in life. It has its little teething problems. And just listen, for years, patients have been telling other patients you have to take your treatment exactly on time, the same time every day, and that's a nightmare. And it's wrong. Okay, so at least they're telling them the correct stuff now. So I'm happy that they are telling them, and people can ask. And is there any problem if someone asks you? Someone else says they take it only when they need to. You say yes. That's a You can do it. Good, great question. So you have to assess what is your need. Do you need to be protected all the time because you're having sex very frequently, or are you having infrequent sex? If you're having infrequent sex, we can offer you that. There's no problem with that. And you know what I'm saying? We all need to learn to talk to our patients. I know we don't have time for it. I know we don't have time for it, but we need to learn to talk to them. There is a recording for this webinar. Just speak to Dr. Lesejo and he'll tell you how to do it. Okay, we've discussed this. Yeah, someone says, Audrey says, 1 month, 3 month, 3 month dispensing cycle we to play with the on-demand venue. Yeah, so we'd have to work out how we're going to do it. You might have to, give them 1 month and then I don't know how it's going to work. Audrey, you and the pharmacist will have to work it out. I don't know the answer to that one. Any drug-drug interaction if taken for Viagra? I haven't checked, but as far as I know, there isn't. But Visecha, maybe you know that. Maybe because they're having sex so often, they need the Viagra. Someone says they've got a patient in mind who needs the 2-on-1 dosing. That's great. Is PrEP safe in pregnancy? Yes, they do say. They say it is okay. Someone said, if there's renal failure, can you give it less frequently? So yes, you can. As I said to you, it is an option if you don't have the other options. You don't have TAF available. Um, so you could do the. So they're asking about doing the renal doses. Yeah, I don't think it's been tested for the renal doses. So I don't know if I would do that, but you could perhaps do on-demand PrEP if the renal function is not too bad. But rather better to get them onto TAF. In our facility, TDF is out of stock. We're about to give TLD for PrEP. Is that okay to do? Yeah, look, I mean, nobody wants to take an extra drug when they don't need to, but um, we know that dolutegravir is well tolerated. So what they're saying is they haven't got tenofovir FTC. They only got tenofovir lamivudine dolutegravir TLD, which has got the extra dolutegravir there. Um, uh, I think it's okay. It's not
Mm.
ideal, but I think it's we have to
Mm.
make do with what we've got.
Mm. Colleagues, I think it's the
So someone
last
asked,
mile. Yes, Leon, you can continue. Maybe take
yeah,
the last two, if any. Yeah.
okay. Um, yeah, someone asked about the same question. I haven't seen any data on using renal doses, um, like giving it every 48 hours or not. So I would be a bit hesitant to recommend it unless there's some data.
Mm.
How long do we repeat a viral after a blip? So in our guidelines, we repeat it after 3 months. Um, but if you want to make sure, let's say that they're on PrEP, or no, they're not on PrEP because there won't be a blip, right? But let's say they're a discordant couple, and you might want to do it more frequently. In our guidelines, would be after 3 months.
Mm.
Women also about what Integra, yeah, of course you could be using Integra, but I think it's very limited in its usage in South Africa. Okay, the Sikh, I think
Yeah.
it's more, lots of them more of the same. And
Yes.
Mervin has just said Viagra and Cialis are only issue with ritonavir boosted PR regimens, so they're fine with PrEP.
Okay.
Thanks, Mervin.
Awesome, awesome. Dr. Leon, as always, what a wonderful, what an empowering session this is. And yes, I don't have a mind anyway because it's been blown away. So now I am mindless.
But
Powerful,
before
power.
people go, let me give you the links to all those documents.
Yes,
So don't run
yes,
away. But keep
yes.
talking, Dr. Lesego.
Yeah, colleagues, just to say that please, I've shared the links in the chat. I've been sharing for the WhatsApp group where you can just join just so that you can get timely updates about our events. Even the links that Dr. Leon will share, I'll reshare again there. I've also shared that this weekend we have the masterclass in ophthalmic emergencies. Please do visit our website and check out the link there in the chat so that you can join if you love issues of the eye. There's always something for you in the eye. And yes, do join us on this incredible journey. This would be very, very valuable. If you can join the membership program and get as much value as you can. If you're asking for recordings and CPDs and certificates, you probably need to join us on this journey. Yeah. So on that note, colleagues, I think let's call it a night. And then Dr. Leon, thank you, thank you, thank you very much. This is very, very appreciated. Yeah,
Pleasure,
let us
pleasure.
keep
Thank you.
equipping and empowering health workers just to improve how we care for our people. Yeah.
Pleasure. Thank you
Um,
for allowing me to bring this message to everybody because when I saw it, I thought I have to get this out to people.
yes,
Thank you.
yes. Awesome. Colleagues, that's it for the night. Night, night, everyone, till we meet again next week or over the weekend if you are going to be joining the masterclass. Bye.
Missed our latest webinar? No worries. We know life gets busy, but your professional development shouldn't have to wait. That's why we've created webinar micro lessons. Short, focused recaps of our full sessions designed to help you catch up quickly and still earn your CPD points. These bite-sized lessons are available exclusively to active subscribe members. So even if you miss a live session, you never miss out on the knowledge or the CPD points. Not subscribed yet? Now's the perfect time to join. Get access to all future webinars, every micro lesson and more. Visit www.clinicalcareplatform.com to sign up